Good afternoon, everyone. Good afternoon, ma'am. Good afternoon, sir. So my topic is fibrin sheath stripping in tunnel catheters. Is it worth a try? If we look at for our nephrologists, very important is the indwelling catheters. Indwelling catheters are the immediate vascular access that we can have for end-stage renal disease patients. And there is another complication which is very well known is fibrin sheath stripping. So what is this strip? This is basically an aggregate of the film that is formed around this catheter. And over time what happens, this sheath which is formed at the tip, it starts encasing the catheter. And there is rapid accumulation of protein aggregates and leads to activation of coagulation cascades. And this leads to thrombotic occlusion and catheter dysfunction. So how do we see this fibrin sheath? CT, it is too thin to be seen on a CT. So what to do? Catheter venography. Catheter venography, when we do, there's an abnormal jet that we see around. That is, it may reflux back into the, at the tip, we can see a reflux back. So if we do the stripping of the sheath and the flow that we see, there is no reflexing back of the dye. And that is in one of a patient that was done. So there are a lot of studies that have been published outside, but not in Indian data. So that fibrin sheath stripping can be done, and it is useful. But what about the Indian data? So for that, we have come about for a plan to study the safety and efficacy of fibrin sheath stripping in tunnel catheters. Since the number is low, we could do a retrospective study. So what are the objectives that we looked for? The objectives were to see the outcomes, whether there is an improvement, no change or complication of each modality used for fibrin sheath stripping, for fibrin sheath management. To assess the outcomes, improvement of fibrin sheath stripping, that is at immediately 1 month and at 3 months. And to study the infectious and non-infectious complications of fibrin sheath stripping, and to estimate what is the mean and the median total number of days from where you insert a port and till the formation of a fibrin sheath. So our study design was, it is a single center retrospective study in which study population was the end-stage kidney disease patients who had an access with the tunnel jugular catheter and had a fibrin sheath formed. And it was, when a venogram was done, it was confirmed with it. And we took the study population from January 2010 to 24 December. And it is done in our center. So the study has been approved by the ethical committee, and the data is obtained from the registry and the electronic hospital system. These are the statistical analysis methods. Our institutional protocol is, whenever there is a catheter dysfunction, which is either blood flow rate of less than 50 ml, that is our institution which we follow, and high pressure or high pressure alarms or inability to withdraw or flush the catheter, what we do is we suspect a catheter occlusion. And if there are not enough blood flow rates, we start by installation of the concentrated heparin into the tunnel catheter. And if it is patent, we reuse. If not patent, then we go for fluoroscopic evaluation because we suspect a fibrin sheath. And if there is a fibrin sheath, we undergo we give option to the patient with explain, and then either the patient undergoes fibrin sheath stripping or a new catheter insertion. So the tunnel catheter that has happened, approximately the number is 4,143, and fibrin sheath stripping has been done in 43 patients, and all of them we enrolled into our study. Immediate success was seen in 42 patients, but one patient unfortunately had a complication, a pneumoperitoneum. After 1 month, we saw that about 10 catheters were not functioning well, in which restripping was attempted in 3, thrombolysis in 1, and balloon dilatation and new insertion of catheter in 2, and catheter exchange in 4. So what results we got according to our objectives? So the first is the mean duration between the catheter placement and the fibrin sheath formation was 70 days, and it was as low as 30 days we found that fibrin sheath was formed. And males were more affected, marginally more affected than females, and median age was around 50 to 30 years in our study. we also noticed that we had mainly patients who had multiple axis failure who chose the method of fibrin sheath stripping. And a prior history of cannulation or CR by SI had 53% and 44% of the patients. The site of cannulation, right jugular was the majorly the main site, and also femoral stripping was done. And the native kidney disease mainly affected was diabetic kidney disease. So according to the studies, these are the other studies which were done, and we see that the highest number was 131, the study done by Brady. And there are other studies in which the patency in the technical success was around 100%. Comparable to our study in which the technical success was 97%, only one underwent a complication, unfortunately. And second we saw was the patency rates. Patency rates was around 72% and 67% at 1 and 3 months. If we see the study, that is balloon angioplasty, which is thought to be superior than fibrin stripping, the patency rate was around 76% and 45% at 1 and 3 months. So this is almost comparable to our study, and at 3 months even it is more than that. Other thing that we found is that at 1 month, the restripping was attempted at 3 patients, because the other patients, 7 patients, underwent thrombolysis or catheter exchange or balloon angioplasty. But technical success was failed. And at 3 months, 2 had restripping, but there was 100%. So we can, though the number is low, but we can conclude that if it is an early strip that is being formed, the technical success rate would be low. But the number is very low to conclude. Complications are, infectious complications were not that high. We could see there were 2 CRBSI though in 43 patients, and 1 exit site infection and 1 pneumopericardium, that is the non-infectious complication. Limitations, retrospective study, limited number of participants, and relatively short duration of follow-up. Conclusion, fibrin sheath stripping effectively maintains the efficacy, often eliminates the need for catheter exchange and repositioning. Restripping rate is lower for early recurrence compared to late recurrence, and risk of over-the-wire exchange, that is reintroduction of port into the catheter, the pre-existing sheath poses risk for repeat fibrin sheath formation. Disrupt the sheath with the balloon may mitigate the risk. Thank you.
In the flow diagram you showed, the total number of catheters were 4,000 and around 40 had dysfunctions in required stripping, but then that will not be the how many had catheter dysfunction. So the more relevant information will be out of 4,000 how many had catheter dysfunction and how many of them had fibrin sheath. So do you have that information?
Thanks for the question, sir. But the thing is that most of the patient don't follow up. So number of perm cats that we insert, and then they go to their hometown, and so we cannot take the exact figure that how many really had a dysfunction.
All right. The other you in the management algorithm you instill high concentrated heparin. So what is the how do you expect it to help? Like for example, somebody has flow problem. The first thing is to put a concentrated heparin lock.
Yes, sir. Yes, sir. So, sir, in case there is a thrombus that is formed inside the lumen or at the tip, that heparin or thrombolysis is going to help in those cases, rather than a patient having a fibrin sheath around the sheath. So what we first exclude out of it is that if there is an intraluminal thrombus, it will dialyze it, and then we usually wait for 30 minutes, and usually the flow returns. So we exclude out this, but still if the flow doesn't return back to it, we go for fluoroscopy to rule out fibrin sheath stripping. Fibrin sheath, sorry.
No, you mean mechanically dislodging, or the heparin is not expected to lyse the clot, right? For that you will have to use a thrombolytic agent. You mean mechanically mechanically dislodging?
Yeah.
Right. You also emphasize that the reason to do is that there's no Indian data. Do you expect the Indian data to be different for any reason?
Yeah, so the cost of the snare is very high. For that, but in case of, there are 2 points to it. One is that the cost is really going to be high, but in cases with multiple axis failure, and where one axis is really important for us, and we want to reuse the same point of insertion, I think for those patients it's really going to benefit.
Thank you.
Thank you, sir.
Do you ensure that these are not infected before you do this procedure?
Yes, sir.
How?
So we usually send paired cultures and then only we go about it.
And what exactly happens to the sheath which you strip? How do you get it out?
Yeah, so there are there is a when we strip out the sheath, sir, it is not that we remove the sheath out, it stays there, and it will get digested there. Not digested, I mean, it will get resolved there inside the lumen itself. It is not that we pull out the sheath, but whatever we could pull out while making the passes, that we take out through the femoral insertion, I mean femoral sheath that we introduced to the, it's a transfemoral route, sir, that from where we take, and while we make passes, we just take out those sheath, whatever we could pull out, and rest of it stays there and gets
And
dissolved.
what do you use for thrombolysis?
Sir, for thrombolysis, sir, we are using retiplase. Thank you, sir.
Thank you very much, Dr. Nividha.